Sorry, that took me so. Which is basically going to be the rest of the arm. So we're going to start with elbow. So this will be elbow part 1. We'll just do the bones and maybe injury today. Wednesday will be online. It will be pre-recorded and uploaded because I will be in Florida, leaving for Florida today to go to Flagler. Friday will be an online activity. Okay? So Wednesday we will not meet because I will be in another state. So, elbow. Made up of 3 bones. We already know the humerus. So the humerus will be our kind of superior bone. And then we're going to have our ulna and our radius. So just like with the leg, the humerus is kind of synonymous to the femur. The ulna and radius are kind of synonymous to the tibia and the fibula. So very similar. So ulna is on pinky side, radius is on thumb side. So for all of these, ignore medial condyloid ridge. You don't need to know that. So the rest, this is what we do. So first we're going to have the olecranon process. So the olecranon process is basically what you probably think of classically as your elbow. So you can see olecranon is right here. So in your elbow, you obviously, probably the thing you know the most is you can feel that point, right? That point is that olecranon process. So on the ulna, there's my hair on it. So on the ulna, we have that kind of C shape where it hooks in to the humerus. So the back portion of the C is going to be the olecranon process. The front portion of the C is going to be the coronoid process. So you can see that C shape. So we're looking laterally. The elbow is kind of hard to get good pictures of. Olecranon process, so this back portion. Coronoid process is the front of the C. Don't confuse coronoid process with the coracoid process. So remember, coracoid is in the shoulder, coronoid is in the elbow. Okay. Radial tuberosity is going to be on the radius. So the radius looks different from the ulna. Ulna has the big C, is much longer. The radius kind of ends, and it looks like the top of like a nail, like a construction nail. So you can see it kind of bows out and flat. So the radius has the head of the radius, which is the top. And then you can see this bump pointing out towards the ulna. So that is that radial tuberosity. Pictured right here, radial tuberosity. Okay. So we're going to have our medial epicondyle, our lateral epicondyle. Don't care about lateral supracondylar ridge. I'm actually going to scoot forward so you can see it on this picture. So this picture is looking at the anterior side of the elbow, straighten out. So again, we can see the front of that coracoid process, or coronoid. Sorry, we made the mistake. There's that head of the radius. We can see that radial tuberosity right there. Now we want to look for our medial epicondyle and our lateral epicondyle. So our medial epicondyle will be on ulna side, and it is this bump, so the kind of the distal end of the humerus. So the part that's poking out this way is going to be that medial epicondyle, and the lateral epicondyle will be this side, the lateral side, radial side. So you can see lateral epicondyle. You'll notice that the medial epicondyle is much larger and more pointed than the lateral epicondyle. So it's another way to orientate yourself, looking which way. So next, we're going to have the coronoid fossa. So here's the coronoid fossa. That is going to be on the front of the humerus. Remember, a fossa is kind of a shallow bowl. You have a shallow bowl shape right on the front. That is to allow, when you are in full flexion, for the coronoid process to sit inside of the humerus. So if that little shallow groove wasn't there, you wouldn't be able to bend your elbow because the bone would just hit onto bone. So you have the coronoid fossa on the anterior humerus, and then we're going to have the olecranon fossa on posterior humerus. So if we flip it around, we can see we have that big groove in the back of the humerus, and that's going to allow the olecranon process to sit and go straight. Okay? So we're going to have what's called the trochlea and the capitulum. So see at the very distal end of the humerus, we kind of have this knuckle shape. So the medial side of this knuckle shape will be the trochlea, and the lateral side will be the capitulum. So you can see on the model, see how we got those three knuckles? So we got trochlea, capitulum. So trochlea medial side, capitulum lateral side. Okay, and we know head of the radius. So what is important to know with the position of the radius and the ulna? So the ulna will always be medial up at the elbow. The radius will always kind of be sitting that way. But think that, remember, radius will always be thumb side, ulna will always be pinky side. So when you turn your arm, the bones actually twist over each other. So they go like this. So they twist back and forth. So that's why when I talked about the anatomical position, why it's so important, because if we're in anatomical position, then the radius will be lateral, ulna will be medial. But if I switch, then I'm going to be pulling the bone over, and now my radius will be medial. So that rotation is important. You got to make sure. Sometimes you'll see people like put the hand backwards compared to these. So the hand goes, and then the radius and ulna follow. Okay. The elbow is technically called a ginglymus joint, or it's basically a hinge type joint. So it's kind of a modified hinge. So it allows flexion and extension. So we know flexion is going to be bending our elbow, extension. But it's going to be modified because it does allow a bit of that, what's pronation and supination. So that twisting of the radius and the ulna over each other. So the elbow is going to be made up of two joints, humeral ulnar, so ulna to humerus, and radiohumeral, radius to humerus. So the elbow is made up of a lot of like ligaments, so it's basically completely surrounded. Then we're also going to have radioulnar, so radius to ulna. So here's a good picture. You can see that ulna separated on its own. You can see that C shape. So you can really see that olecranon process, that coronoid process. You can also see this little radial notch on it. So basically, the radial ulnar joint is a pivot joint. So that's what allows the radial head to rotate on top of the ulna, so allowing that twisting motion. So if you see the bone, you can see that radius is able to freely twist on that ulna because of the radial ulnar joint. So we also, just like in the lower leg between the tibia and the fibula, we're going to have that interosseous membrane again. So the space in between the radius and ulna is filled with that interosseous membrane. It's going to be that spider web-like going in between. So kind of keeping the bones apart, keeping the space. Okay. So ligaments. You don't need to know any of these ligaments, basically. I'm just showing you them. I'm not going to test you on them because there are a lot of ligaments in the elbow. They're not super easy to identify. They're pretty hard to identify, actually. So I think it's kind of above the realm of what you need for this class. But basically, the stability of the elbow is going to be due to all these ligaments. And probably the one that you've heard the most is about the medial ulnar collateral ligament. So medial side to ulna. So this is what's going to provide that medial support to the elbow. So this is what is torn in a Tommy John procedure. So you've probably heard Tommy John in baseball especially. So usually baseball players will tear their medial ulnar collateral ligament via throwing. So they're going into flexion and abduction, throwing, and they're tearing that. That's all I want you to know for ligaments. Okay, carrying angle. This one you do need to know. So when you have your arms by your side, you may notice in some people that their forearms tend to deviate or point a bit laterally from the rest of your body. So that's it. If I put my arm at my side, my hand is not perfectly at my side like this. If I stand and relax, you can see my arm goes out. That's my carrying angle. So that kind of curve that I have is my carrying angle. Could be around 5 to 15 degrees. So it allows, when you are walking, to have your forearms clear your hips while you're walking. Because if we didn't have that carrying angle and our arms are perfectly straight, it'd be a little hard to walk. So you're going to have a slightly larger carrying angle in your dominant arm over your non-dominant arm. So I have a dominant right arm over my left, so I have a larger carrying angle in that one. And women also have a greater carrying angle than men. I also personally think that's because women tend to have larger hips than men, so they need a larger carrying angle to clear their hips. So that's another postural assessment you may notice. So perhaps in someone who is having medial elbow pain and you have them stand in a position to assess their carrying angle, if you notice that one arm is super deviated out while the other isn't, possibly that could be an issue resulting in an injury. So range of motion, we're going to know our classics. So flexion, bending our elbow, extension, straightening our elbow. You may have hyperextension in some people when they're able to extend past kind of 0 degrees. You'll often see that in women again. That's just because they have a deeper olecranon fossa than the rest of us. So they have more room to go while we don't. Then we're going to have pronation and supination. So pronation is basically going to be that twisting of the radius on the ulna. So pronation will be doing that twisting and palm will be going down. So anytime we're palm down, we're in a pronated position. And anytime we are palm up, we are going to be in a supinated position. So that's kind of like supination, you think of holding a soup bowl. So pronation, palm down, supination, palm up. Okay, so some common pathologies with the elbow. We're going to have what's called tennis elbow, which you've probably heard. That is actually called lateral epicondylitis, is the true name for that. We're also going to have golfer's elbow, which is medial epicondylitis. And then we'll have that UCL tear. So remember, anytime you see itis on something, that just means inflammation. So lateral epicondylitis is an inflammation of the lateral epicondyle. So this is called tennis elbow because of a muscle that we'll learn next time, the extensor digitorum. So that muscle, when especially in tennis, it contracts really hard and pulls on that lateral epicondyle, creating that inflammation. So in a lot of gripping or lifting activities, people will have that lateral epicondyle pain, so they'll have outer elbow pain. Medial epicondylitis, so inflammation of the medial epicondyle, is known as golfer's elbow. So that is because all of the wrist flexors, so what curl your wrist, all attach on the medial epicondyle. So all of the wrist extensors attach on the lateral epicondyle, all the wrist flexors attach on the medial epicondyle. So when you're golfing and you're constantly doing wrist flexion, it pulls on the medial epicondyle and creates that inflammation. It's a bit less common. And then the UCL tear, basically that ulnar collateral ligament that I talked about, usually through throwing, is one of the ligaments you'll see. But that's usually in a throwing activity. You don't typically get hit in your elbow and damage it. Obviously, as with every joint, we're going to have potential fractures and dislocations. Dislocations of the elbow are going to be more rare. And if they do happen, they need to be seen by a doctor immediately. It's not one that can be reduced by an athletic trainer or physical therapist. It'd be very difficult. And you'll actually see elbow dislocations in kids a lot. That's because usually parents grab onto their hand and kind of yank them away from whatever they're doing, and it will dislocate their elbow. So I actually got my elbow dislocated when I was a child, because I climbed to the top of a blood pressure machine in Walmart and wouldn't get down, and my mom pulled me down and I dislocated my elbow. But it's super easy to put them back in because kids are so kind of bendy and their bones are not fully formed. So all the doctor had to do was he put a lollipop up near my face, held my other arm down, and I went and grabbed it and I popped it back in. Okay, so that is all you're going to do today. We're in the last kind of final stretch, so we really don't have that much to do. So a lot of these are going to be spread out a bit more just to try to make it through the year. And then we'll finish the last few weeks kind of with our little project thing that we're going to do. So we'll actually finish all of this before the end of the school year, but we'll work on our project. But you definitely will not be taking a final during final exam week. You'll be done before then. Okay. So Wednesday, online activity, not a live meeting, pre-recorded and posted. Friday will be a online activity